Hi, everyone. Thank you for joining me for ASAP's Capital Minute, a look at what's happening in Washington right now that's affecting emergency physicians and patients. I'm Laura Worcester. For the next 30 minutes, I'm going to give you an update of what's happening in our nation's capital, and then we'll open it up for questions. You can submit them at any time during my update by using the Q&A feature at the bottom of your screen in Zoom, and then I'll answer them live at the end. Here's a taste of what we'll cover today, such as Physician Suicide Awareness Day, an update on the latest COVID relief package, the proposed physician fee schedule cuts, new hospital reimbursement policies from CMS, ASAP's participation in a panel to discuss telehealth and APMs, and a November elections preview. Today marks Physician Suicide Awareness Day, a critical issue for ASAP and one that impacts far too many emergency physicians. ASAP is using today to highlight our advocacy efforts to ensure that you can safely secure treatment for mental or other health issues that do not affect patient care without repercussions to licensing, credentialing, or future employment. We continue to work closely with Jennifer and Corey Feist, the sister and brother-in-law of Dr. Lorna Breen, an ASAP member who we tragically lost to suicide in April, to raise awareness with policymakers and the public. In addition to a series of videos to highlight the issue, which you can see on ASAP's Twitter and YouTube pages, ASAP President William Jaquess also co-authored an op-ed with the Feist that was published today in the Dallas Morning News and highlights the unique toll the pandemic has taken on those on the front lines. All of these activities help shine a brighter light on the emotional toll emergency physicians face and the struggles that you encounter when trying to seek mental health treatment and advance our legislative efforts. ASAP continues to support and inform physician mental health legislation in Congress. Emergency physicians strongly support the bill, the Dr. Lorna Breen Provider Protection Act, which we work to introduce in the House and Senate, and other similar legislation from Representatives Raul Ruiz and Raja Krishnamurthy, which aim to expand resources for physician mental health. As you may remember from previous Capital Minutes, we were hoping to include the Dr. Lorna Breen Healthcare Provider Protection Act in the next COVID-19 relief package, so I'll give you a quick update on where that stands. Last week, the Senate failed to pass its skinny bill, which included roughly $1 trillion, and House Speaker Nancy Pelosi and Treasury Secretary Steve Mnuchin have still not yet reached an agreement. While we've not had a new relief package passed since April, the outlook of getting something passed before the November elections is looking bleak. That leaves our best hope to get something passed for this session during the lame duck session, which is after the November 3rd election and before the new Congress takes over in January. In addition to our advocacy efforts around the COVID relief package, ASAP is also trying to stave off potential Medicare reimbursement cuts that are expected to hit in 2021. Recently, the Centers for Medicare and Medicaid Services, or CMS, issued its proposed 2021 Medicare physician fee schedule. Thanks to sustained ASAP advocacy, we were successful in securing an approximately 3% increase for the ED/E&M codes. Unfortunately, CMS's budget neutrality rules require that the substantial reimbursement increases slated for primary care E&M codes necessitates a corresponding decrease in the value of all other codes, ultimately meaning that our hard-won increase has been canceled out by CMS rules. Immediately after the proposed rule was released, ASAP sent a letter to Congress sharing our concerns, asking them to help alleviate these upcoming cuts. Several legislators have taken notice and have begun working on bipartisan efforts to prevent these cuts. Representatives Roger Marshall and Bobby Rush are circulating a bipartisan sign-on letter to HHS Secretary Alex Azar and CMS Administrator Seema Verma, asking them to delay or mitigate the impending cuts. We need your help now to send a message to your member of Congress asking them to sign on to this important letter. The more voices on it, the more that CMS will take notice. Additionally, Representatives Ami Bera and Larry Bouchon are developing legislation aimed at addressing these cuts, and we will keep you informed as we work with these legislators and as more details become available. As well, ASAP, with support from the Emergency Medicine Policy Institute, is running a paid digital ad campaign during the next few weeks, urging members of Congress to waive budget neutrality and prevent these cuts for 2021. You can see an example of one of these ads on the screen, but we need your help to send a message to Congress to prevent these damaging cuts. You can use the link on your screen to send an email to your representative asking them to sign on to this important letter. Last month, CMS released its proposed regulation for the 2021 Outpatient Prospective Payment System proposed rule, the major annual Medicare regulation that sets rates for hospital outpatient services. Although CMS does not propose any changes to current emergency department payment policies, CMS does include a proposal that could still indirectly affect your patients. In the rule, CMS proposes to eliminate the inpatient-only list over a 3-year transitional period, with the list being completely phased out by 2024. This is a list of procedures which currently can only be performed in a hospital inpatient setting. Procedures removed from the inpatient-only list will eventually become subject to the so-called 2-midnight rule. ACEP has long expressed concerns about the 2-midnight rule and its implications on beneficiary cost sharing. Under the rule, patients that spend less than 2 midnights in a hospital are treated as an outpatient, while patients that spend more than 2 midnights in a hospital are treated as an inpatient. The difference between having an inpatient and outpatient status on patients is profound, because Medicare generally covers most of the cost of inpatient services, while forcing beneficiaries to pick up a pretty big portion of the tab for their outpatient services. Unfortunately, many beneficiaries don't even know that they are actually outpatients. If they are in the hospital, they assume they are inpatients, understandably, and are subject to the inpatient Medicare rules. All in all, the onus will be on CMS to ensure that Medicare beneficiaries clearly understand their cost-sharing obligations if they receive one of these procedures that's being removed from the inpatient-only list. In addition, CMS is revising its policies regarding resident transfers when hospitals close or announce that their residency programs are ending. Specifically, instead of linking temporary funding for the affected residents to the day prior to or on the day the hospital or residency program closes, the determining day will instead be the day that the closure was publicly announced. Further, CMS is allowing funding to be transferred temporarily for residents who are not physically at the closing hospital, but the facility they intended to train at or return to train at. ACEP, along with EMRA, strongly supports these policies as a means to protect our residents and provide sufficient funding to teaching hospitals that take place in displaced residents, so we were pleased to see them included. Yesterday, ACEP's Regulatory Affairs Director, Jeff Davis, participated on a panel discussion about the role that telehealth can play in alternative payment models, or APMs. During the discussion, which was hosted by the Physician-Focused Payment Model Technical Advisory Committee, a mouthful, also known as PTAC, this is a federal advisory committee that recommends Medicare alternative payment models to HHS. Jeff emphasized the growing use of emergency telehealth services during the COVID-19 public health emergency and how that's helped to lead the way for emergency physicians to use telehealth as a tool to improve patient outcomes and lower costs. He included representatives from groups that previously submitted APM proposals to the PTAC. Each of the proposals had a telehealth component in it. On behalf of ACEP, Jeff discussed how telehealth was incorporated into the acute unscheduled care model, ACEP's model that was previously recommended for full implementation by the PTAC back in 2018. The telehealth waiver that we included in the AUCM represents a tool that emergency physicians could use to provide follow-up services when the beneficiary has been discharged and is at their home. The use of telehealth can improve patient outcomes and lower costs by helping to ensure that patients discharged from the ED are appropriately following their discharge plan and are receiving any additional services that may be necessary to prevent a trip back to the ED or even an inpatient admission. Jeff also discussed the increased use of telehealth during the COVID-19 public health emergency and what needs to happen going forward to completely eliminate barriers to telehealth, which could ultimately threaten the success and progress we have seen in telehealth. All in all, we underscore that there's a great potential to increase value in the system by getting emergency physicians engaged in the care continuum for patients, and that telehealth is a key tool to help accomplish this goal. Looking ahead, the November elections are quickly approaching. During our next Capitol 30 Minutes on October 1st, we're going to devote the episode to providing you with an elections preview. In addition to highlighting which races we're paying close attention to and top legislative issues for emergency medicine, we'll provide you with an update on our advocacy efforts through our National Emergency Medicine Political Action Committee, or NEMPAC. In the meantime, I encourage you to check out ACEP's Voter Resource Center, a nonpartisan resource where you can easily check if you are registered to vote, how to vote early or request an absentee ballot, find out who's up for election in your area, and learn more about the ways you can get involved, including support for NEMPAC. That wraps up our federal advocacy updates, so I'll start taking your questions. Remember, you can submit them using the Q&A feature of Zoom on the bottom of your screen. Let's see what comes in. All right, first question's coming in. Provisions in the Breen bill seem incredibly helpful. If the Breen bill or other mental health legislation doesn't get included in the next relief package, are we hopeful about passage during lame duck or reintroduced during the next session? Absolutely. We've heard from a lot of members of Congress when we talk to them about this issue and how important it is that they really want to make sure this gets done. I think in the lame duck, we have a pretty strong chance of it being included. I think what it'll come down to is how broad a lame duck package will be. And there's a lot of kind of variables that end up determining that. And I think certainly this year, the outcomes of the election in one manner or the other will, I think, help determine how expansive or how narrow the lame duck will be. I think kind of depends on what happens, and I don't even know really which outcomes would result in, let's say, a narrower lame duck package versus a more expansive one. I think how long it takes to get election results in will be a big part, and we'll talk about that a little on our next Capitol Minute in our election preview. That, this, unlike other elections, because of all the COVID processes that are changing election processes, it may take a lot longer to get election results than we are used to, and that will spill over then into work that Congress does in that interim. So I think if people are still waiting to find out if they're staying in Congress or not, it may change a little bit their behavior or how kind of willing to go out on a limb they are in that lame duck session. A lot of times when someone is voted out of Congress, they sort of feel empowered to really do much more what they personally want to do on a piece of legislation than they might have before when they need to worry about re-election. And with members in the House, at least, having to run for re-election every 2 years, you essentially start campaigning for your next term the day after the election. So it impacts a lot how they'll act during the lame duck, whether or not they are coming back in the following term or not. So we'll keep an eye out on that. But I think we have a good chance of getting it done in the lame duck. If we aren't, I think the new Congress will certainly provide new opportunities for that. I think COVID will still be very much top of mind, and being able to tie the legislation to what emergency physicians and other health providers have gone through during the pandemic in terms of stress and burnout will make a much easier case, and I think will help move this along in one way or the other. All right, next question is, can you provide the latest info on surprise billing issues? Yeah, so surprise billing, I think we talked about it last time, still sort of continues to be in play. It's in play in the sense that some of the committees that were not friendly to physicians or emergency physicians especially, were trying to get it added to the next COVID package. They've tried to get it added to every COVID package that's come along so far. And so far have been unsuccessful due in large part to our advocacy along with some of our specialty partners. So they're still trying to do that, and I imagine they will have a very large effort, even larger effort, to do it during the lame duck. So then going back to what I just said about the lame duck and what that's going to look like, I think it really remains to be seen, but we're certainly prepared to tackle it in one form or another during the lame duck. ACEP will continue to advocate for our preferred approach. We were the first physician group, I believe, to support the Ways and Means bill, and we'll continue to push for that. Chairman Richie Neal from the Ways and Means Committee, he luckily won his primary, which I think was last week, which at one point was expected to be a pretty close race, but he did win his primary, and he's expected to win the election without any issue in the general election. So that'll help us in terms of having a champion for our preferred approach. And we'll keep pushing back and educating and re-educating, because people have short memories these days in Congress, on why the median in-network approach that the Senate Health Committee or House Energy and Commerce Committee are trying to push would be very damaging, especially to emergency physicians and the care you all provide to emergency patients across the country. Right. So another question is, do you see potential for surprise billing to get included in budget extenders must-pass legislation? So I actually think the really must-pass legislation is less likely to have surprise billing in it. That's more just my personal kind of gut feeling. That doesn't mean it couldn't happen by any means. And that's because surprise billing has been very controversial and proven to be a big challenge for leadership in the House and Senate to have move forward, really. They've had to do a lot of balancing amongst their members and their caucus to on this issue. Sometimes I think unexpectedly when they didn't expect to. And I think it's not, as a result of that, it's not exactly their favorite issue in terms of being able to rely or predict what's going to happen with it. So I think if you have like really kind of must-pass legislation, which budget extender certainly would be, that if that starts to get tied in with surprise billing, then you risk not being able to pass that must-pass legislation. That being said, some of those preferred approaches for health and energy and commerce, they score as saving the federal government a lot of money. The budget extenders cost a lot of money, so that starts to then be a little dangerous in that it could be used to help pay for that. But again, I think it's a little tenuous of an approach or strategy because it could blow the entire thing up and then you're left with really nothing. Another kind of milestone that's happening is that the current funding for the government expires at the end of September. And so Congress is working on that in the short term, though they're likely to pass what's a pretty narrow continuing resolution or CR either this coming week or the week after. The House is probably going to pass it early next week. The Senate could pass it before the 25th of September, but it's more likely to go all the way to the end. And that's because even just the CR is going to be a little controversial. You've got an election coming up, and some people could try to leverage that as an opportunity to either push for a government shutdown, as disastrous as that would be, or make the other side, whichever side that is, in their perspective, look bad by having inaction. So as you get closer to September 30th, the more pressure there is for the Senate to pass something. And I guess that's why we think it may push a little later or much closer to September 30th than probably anybody is really fully comfortable with. But we're certainly not expecting surprise billing to be in that, for example, because that really has to pass. So from Leader McConnell's perspective, if he suddenly allowed surprise billing to be included in it, it would make things a lot more complicated, and there isn't a lot of time before September 30th to take care of all that. How can we so here's another question. How can we support efforts to make sure legislation that mitigates the fee schedule cuts gets through the House? So the most immediate way you can support that is we had that link before on the screen about how to take action through our advocacy and grassroots network. And you can send your House member a message telling them to get on this letter that's being led by Representatives Marshall and Rush that's going to CMS, telling them to hold physicians harmless on these cuts. That's going to be the most immediate thing that you can do. That's pretty important. I think it'll signal to CMS that they need to do something and buy a little time. And then we have Congress that's working on kind of a more long-term legislation to address this. CMS has been saying that they can't stop these cuts without Congress doing something, that they don't have the statutory authority. Meanwhile, Congress, up till now, has really been feeling like this is CMS's problem. They created it. They need to fix it. But I think they're starting to realize that this is actually going to happen if they don't do anything. And so now they're working on legislative approaches to stop this. And there's different strategies that are being worked on or mulled over. So once that legislation becomes a little more advanced or is introduced, we'll be coming back to all of you and asking you again, to write your members of Congress to support that particular legislation. So near term is getting as many members of Congress on that letter to CMS, and then longer term, we'll be reaching back out to you to get support for legislation that's introduced. All right, so there's another question. The AUCM, that's ACEP's Acute Unscheduled Care Model, APM, sounds very promising. How would you characterize the reception that the model is getting? I think it's actually getting really good reception since we really advanced it through the process. The PTAC recommended it pretty strongly for implementation to HHS, and that recommendation does hold a lot of weight. Now the secretary has accepted it and is going to signal that they will be implementing it. Unfortunately, there's a pretty big backlog and long time frame on that. We're not sitting around just waiting for CMS to take it on, though. We have been meeting with a number of private payers, private insurers, and state Medicaid agencies to meet with them and see if they'll start implementing it as a kind of voluntary approach. And we have gotten really good reception on that. And so we're pushing that forward, and we hope that we'll be able to share with you in the future that this is being implemented in different areas, and that emergency physicians do have the option of participating in the AUCM if they'd like, because all along we've said that this needs to just remain a voluntary model. Different practices, different environments, different geographical areas lend themselves to this more than others, and we want to make sure nobody's forced into something and have to change their workflows or business practices under any type of mandate. So stay tuned on that. We'll be developing some additional materials to help ACEP members talk to their own commercial insurers that they contract with, or even their state Medicaid offices, to encourage them to implement this model. So we'll have more of those materials out there. You can read more on this and look at our current toolkit of materials by going to acep.org/APM. I think you can also go to /AUCM. Both of those links should work, and that's where you'll see all of our toolkits and information for more on that. Okay. CDC, CMS, and others are doing a lot of impactful work behind the scenes. Could you talk about whether these agencies are getting increasingly political and the role of ACEP as a nonpartisan medical expert? I think that's a really good question. There's a ton of work that has always gone on behind the scenes in these agencies. CMS, of course, being the one that impacts emergency physicians, I would say, the most. What happens in terms of if they're getting increasingly political? So there's always going to be a political angle on them. You have career employees at these agencies, and those are the people that apply for a job there. It has nothing to do with their political affiliation. They do their job no matter no matter which presidential administration is in charge. They continue to stay there and continue doing their work. So they're the ones who really get stuff done and who we have the most contact with in the day-to-day regulatory advocacy that we do. So those are really important relationships. You then also have political appointees who can be sometimes in more senior positions at the agencies. And those do change from one presidential administration to the next. Some can be asked to stay on by a new presidential administration, but many will just change over and have new political appointees chosen each term or each presidential election cycle when a new president is elected. And so those are where things start to get a little more political. And if you have an administration that's trying to advance policies that maybe aren't as favored by those in Congress or the general public, they may have those political appointees try to work the changes through the process and put pressure on the career staff there and get those through. It doesn't always work, and I think we've seen some recent examples of where there's been media coverage of some of this political pressure, and in the end, it's resulted in either policies being kind of rolled back or just some of the political pressure stopping. So that that's always been something that happens. I think more recently with COVID in the last couple months, it's kind of come to a head, and there's a lot more media scrutiny on it now just because of some past things that happened. So you're hearing a lot about it, but even while that's all going on, there's still a lot of very nonpartisan, very trustworthy, very, I think, motivated career employees at these agencies who we continue to work with every day, who, you know, look to ACEP as a great resource, and vice versa. We look to them as a resource as well. And we continue to kind of get stuff done as we work on these important issues. And I think the APM, the alternative payment model, is exactly a good example of that. And then in terms of the role of ACEP as a nonpartisan medical expert, that's something that we always take very seriously in our efforts. We want to make sure that we not only are a nonpartisan medical expert, but that we are perceived as such, because I think that's a really important part. And so sometimes that complicates how we might respond to an issue, or let's say we are advocating on a certain bill. If the bill is very strictly partisan in that it only has like 40 co-sponsors, let's say, of one party, it starts to be a little complicated in that if we push that to what would be the other party, we may be viewed as too tied into that first party who has all the supporters on the bill. So it's a little bit of a balancing act. And I think it's part of kind of what makes sometimes congressional advocacy more of an art than strict science or just procedural thing that we do. It's not quite so straightforward, and you kind of have to read the room and be careful of some of these potential landmines, and being painted as too affiliated with one party than the other, because that could really hurt you in the months ahead in terms of other issues that you're working on. So that's something we work strongly to do. And then even with NEMPAC, we really look at our giving to make sure it mirrors pretty closely the makeup of Congress. So if Congress 1 year in the House, let's say, is 65% Republicans, our NEMPAC giving is probably going to be pretty close to 65% to Republicans in the House. And that's because it's mirroring the makeup of Congress. It wouldn't make sense to only give to, let's say, 40% of the Republican members in the House in that sense. So we try to keep it as balanced as possible. And often that balance is just reflecting the balance in Congress itself. All right. Another question, ACEP 20 is approaching. What are you looking forward to most? I think this is either the last question or the before last. Yeah, we're just about running out of time. Actually, we are just about running out of time. ACEP 20 is approaching. What are we looking forward to most? There's a couple different things. Looking forward to seeing what Dr. Anthony Fauci talks about. Speaking of government officials and potential politics around that. He certainly has, I think, done a remarkable job of trying to stay as neutral as possible and sticking to the science. So I think it's great that he wants to speak to emergency physicians, and I think recognizes the role we have played in the pandemic. So looking forward to his remarks. And then I'm also looking forward to some of the fun things that NEMPAC will be doing to engage everyone. We can't do a reception in person this year, unfortunately, so we'll have some great alternatives that are coming. I don't want to give those away, but the best way you can find out about those is to sign up for ACEP 20. We hope you'll register and join us, because there'll be a lot of fun activities, and there'll still be tons of opportunities for networking and virtual coffees and seeing your colleagues that you normally don't see other than at Scientific Assembly. So you want to learn more, you can go to acep.org/ACEP20 and see what the details are for registering. And hopefully we'll see you on screen in one form or another there. So that's all for now. So thank you for joining us. And we'll be back in October 1st for an election preview. Thanks again.